work in clinical and research field. His interests include clinical trials on rheumatoid arthritis and biologic therapy. In addition, he is a friend of Dr. Muhammad al-Niman. Dr. Mahmoud, please.
Good morning, ladies and gentlemen. Thank you, Mr. Chairman, for your introduction. It's a great pleasure and honour to be here, so thank you. My first topic is about biologic therapy, principally restricted to patients who have RA, though some of the general principles apply to other rheumatic conditions such as psoriatic arthritis or ankylosing spondylitis. So my talk is going to talk about the therapeutic options to treat rheumatoid arthritis with biologic drugs, some of the potential problems that can arise, and offer treatment. I'll go with them. What is biologic therapy? Well, I'm sure many of you will know. In rheumatoid arthritis, it's the use of specific molecules to target parts of the pro-inflammatory cascade to try and suppress inflammation in joints. And this is a cartoon of what might represent the pro-inflammatory cascade, a complicated picture involving dendritic cells, macrophages, antigen-presenting cells, talking to T cells, causing T cell activation, and the production of pro-inflammatory stimulators such as TNF, interleukin-1, and interleukin-6. And to treat rheumatoid arthritis, there are 4 classes of biologic drugs available: anti-TNF therapy, or TNFi, B-cell depleting therapy, and anti-IL-6 therapy, and also co-stimulatory blockade. Thinking about anti-TNF therapy to treat rheumatoid arthritis, there are 5 agents currently licensed, and they fall into 2 classes. Etanercept, which is a soluble TNF receptor, and then the monoclonal antibodies, of which there are 4 listed there. Most of them are given by subcutaneous, self-administered injection, and infliximab given by IV infusion. Now, in UK practice, the use of anti-TNF therapy, we are bound by quite strict guidelines, which not all parts of the world obviously follow. But UK practice says that patients need to have active rheumatoid arthritis and must have failed 2 standard second-line drugs or disease-modifying drugs, of which one must be methotrexate. Methotrexate is still considered the gold standard second-line drug, and any new agent that comes out to treat RA, the comparator drug is always methotrexate. But how do you define active rheumatoid arthritis? Not an easy question to answer, maybe. There's not one parameter that can be used. And what is generally accepted is a scoring system called the Disease Activity Score, which uses 28 joints, hence DAS 28. And that looks at these 4 individual parameters here: number of swollen joints, number of tender joints, the ESR, and the patient's global assessment of their general health on a 10 centimetre visual analog scale. There's a Archimedes equation there where these 4 variables are entered into: total number of tender joints, swollen joints, the natural logarithm of the ESR, and the VAS, and the number comes out the end. Thankfully, as you might imagine, there are many online calculators to calculate DAS 28. One doesn't have to carry these numbers around in one's head, and this is one of them that's freely available. You can see that 28 joints that are counted, as it were, are the PIP joints, the MCP joints, the wrists, elbows, shoulders, and knees. It doesn't include the forefeet. The forefeet is the most common site of rheumatoid arthritis, but a DAS 28 seems to perform just as reliably as using a bigger joint score, which would involve 68 tender and 66 swollen joints. So in routine clinical practice, the DAS 28 would be used. And And then the 4 variables are entered in this example of a patient with typically very active rheumatoid arthritis. They have 11 tender joints, 10 swollen joints, and typically the MTP joints, wrists, elbow, knee, the ESR's high, and the patient's feeling pretty bad, giving himself a global of 68, remember 100's terrible, 0's fantastic, so they're towards the bad end of the spectrum. And that generates a DAS28 of 6.62, which would be considered very active rheumatoid arthritis. In UK practice, the DAS28 has to be greater than 5.1 to qualify as a word for anti-TNF therapy. If your DAS28 is less than 5.1, unless there are other reasons, anti-TNF therapy would not normally be used. I think it's important to remember that these are guidelines, of course, particularly for UK rheumatologists, there are laws, but they would generally be followed. And it's accepted that a DAS score of 3.2 to 5 is moderate disease activity, 2.6 to 3.1 is low. And a DAS score of less than 2.6 is said to represent remission. There are many limitations with DAS28, however. It's not diagnostic of active rheumatoid arthritis. If you have fibromyalgia and osteoarthritis, and you've got an intercurrent infection, then you may well have lots of tendon areas, you may well have a modest elevation ESR, you may well have a high VAS score, general health score. So it's not diagnostic of active rheumatoid arthritis, and it does depend on an experienced clinician to interpret DAS28 correctly. And bear in mind that 3 of the 4 parameters are subjective. What I consider a swollen joint, someone else might not consider a swollen joint. How hard I press in a joint might be different from how someone else presses, and of course patients' VASs and talisons are subjective. And patients may still have synovitis and be in so-called remission. So here's a patient with 2 tender and swollen knees, important joints, we're not just talking PIP joints here, important joints, but the ESR is low. They've given themselves a relatively low global health score of 17. Perhaps because their arthritis used to be absolutely terrible, and now they consider this pretty good. And that was said to represent remission, but clearly it doesn't. So limitation of the DAS28. How effective are anti-TNF drugs? Well, if you'll excuse me going into a little bit of rheumatology trial minutiae, this is one way of interpreting how active these drugs are. And often this score called the ACR 20, 50 and 70 response rate would be used, and that means an improvement in the number of tender joints and the number of swollen joints, and 3 out of the 5 of the 5 parameters listed there. So if we think about patients in a clinical trial, for instance, everyone comes within the board. Those patients who are ACR 70 responders would come in here, ACR 50 responders would be here, and ACR 20 responders would be here. So if you're an ACR 70 responder, you are by definition an ACR 50, an ACR 20 responder. And in general terms, there's a 60-40-20 rule, which says that in trials, at least of RA patients who have active disease, despite being on methotrexate, so of course that's a subset of patients, but those patients who have severe enough disease are still active despite methotrexate, who then start an anti-TNF agent, about 20% of them, 60% of them will be ACR 20 responders, 40% ACR 50, 20% ACR 70. And what that means in practice is an ACR 20 responder, you start the patient on the drug, they come back after 3 months or so, you say to them, well, how are you getting on? An ACR 20 responder would say, well, I'm actually quite a bit better than the joints, a bit less tender and swollen, and less stiff in the morning, and more active. ACR 50 responder would say to me, I am definitely better, doctor, I am much better than I was before, I'm doing a lot more, hardly stiff in the morning. ACR 70 responders come in and say, I am absolutely fantastic. My joints are much, much better. Please can keep going with this drug. I'll put up the side effect A, B, and C, but I really want to keep going. I am much, much better. That's the typical clinical response. And this is the same thing in graphic form. So 4 of the anti-TNF drugs listed there. Paracetamol, infliximab, adalimumab, certolizumab, and about 70%, 70% across the board are ACR 20 responders, about 40% across the board ACR 50, and about 10 to 20% across the board ACR 70 responders. Important to note that a third of patients, however, do not respond at all. So these are patients who have failed 1, probably 2 second-line agents, almost certainly will be methotrexate. They will now fail an anti-TNF drug, a very hardcore of patients. As important for the long term for symptoms and signs of active arthritis is, of course, X-ray changes. And this is a graph showing the change in the SHARP score, which is one way of scoring X-rays to look at erosions in joint space and narrowing for, again, 4 of the anti-TNF drugs. And the anti-TNF drugs perform better with patients who are on methotrexate. And there's lots of data to suggest that etanercept plus methotrexate may actually lead to healing of some erosions, although that's a more controversial statement. In general terms, anti-TNF drugs are more effective if given with methotrexate, so that's my preferred option. And anti-TNF drugs and methotrexate are more effective in non-smokers. So another reason to try and persuade the patient to stop smoking. Going on to the other classes of biologic drugs, rituximab, also used to treat lupus, as our former speaker mentioned. B-cell depleting therapy, a monoclonal antibody against CD20, which is found on the surface of B cells, and that is the B-cell depletion. Initially licensed to treat lymphoma, its rheumatoid arthritis license is in patients who have active RA who have already failed anti-TNF therapy. And the rheumatoid arthritis dose is 1 gram intravenously 2 weeks apart. It's more effective if given with methotrexate, and the median duration of benefit in trials at least is around 9 months. There's also some evidence to suggest that it may be more effective in patients who are seropositive for rheumatoid factor or anti-CCP antibodies. There is a risk of infection in patients who are on rituximab, although obviously that's true with most of the drugs used to treat rheumatoid arthritis. There's a risk of progressive hypogammaglobulinemia, the more rituximab is given. And a lot of it is made of PML, progressive multifocal leukoencephalopathy, a serious progressive brain disorder caused by reactivation of JC virus. And that's, in my experience, put a lot of patients off being on rituximab, particularly those who are into clinical trials. Now, there's been about 125,000, 130,000 patients across the world treated with rituximab for rheumatoid arthritis, and about 10 to 12 cases of PML associated with that. So the risk is very, very low. But in my experience, disproportionate disincentive for patients to actually receive the drug. Tocilizumab therapy, the third class of biologic drug, is anti-IL-6 therapy. It's a monoclonal antibody again, this time against the IL-6 receptor, given by monthly IV infusion. Now, this may be more effective than anti-TNF drugs in patients with RA who have not had any form of biologic therapy, who are intolerant of methotrexate. There are few head-to-head trials of biologic drugs in RA, but one published last year suggested that this group of patients, i.e. RA, who are intolerant of methotrexate, who have not been on any form of biologic drug, the tocilizumab may be a more effective agent than the current standard approach, which would be given anti-TNF drug. Safety concerns, usual things, but with tocilizumab also dyslipidemia. I'll come on to a bit more of that in my second talk. And caution for the history of GI ulceration, particularly diverticulitis. That's different, of course, from diverticulosis, which is relatively common. That's not a contraindication for tocilizumab, but diverticulitis would be considered a relative contraindication. And the fourth group, co-stimulatory blockers, abatacept. This interferes with the androgen-presenting presenting cell talking to the T cell, in that there needs to be two signals between the two for the T cell to become activated, and a beta set blocks the second co-stimulating signal. It's the most recent biologic drug that has become available to treat RA. Given by monthly infusion initially, though there's now a subcutaneous preparation available. And the 5-year safety data in this drug are relatively reassuring, though this is 5-year follow-up safety data on patients who are in clinical trials who were then followed up for 5 years. So it's not everyone on a beta set, and it's not everyone on a beta set who's in a clinical trial, it's those patients who are still on the drug after 5 years. Of those patients, there were no new safety signals developing over that period. But of course, trial data is different from real-life data. Trial data is good, but it's often not the patients we see in clinic who may have reasons why they cannot enter clinical trials because of comorbidities, for instance. And in an attempt to address that, there are several registries held in several countries now of patients on anti-TNF drug, principally. One of the largest ones is the one in the UK, held in Manchester, British Society of Rheumatology and Biologics Registry. And this is a prospective cohort of UK RA patients who are on anti-TNF therapy compared to RA UK patients who are on standard second-line drug therapy. And reasonable patient numbers, certainly for a rheumatology population, these are large numbers. Appreciate for cardiology trials, for instance, that may be standard, but for us, these are big, big numbers. And I'd say real-life data compared to data from clinical trials, which is a subset of patients, obviously. One concern with anti-TNF drugs has been interstitial lung disease, and this arose from a series of 3 patients published in the BMJ. All had active rheumatoid arthritis, all had background stable, known about interstitial lung disease associated with RA. The patients received anti-TNF therapy and probably died from accelerated interstitial lung disease. This wasn't a signal that arose in the trials at all, so this was something that shocked the rheumatology world. And of course, medicine's not straightforward, clinical trials aren't straightforward, patients aren't straightforward, science isn't straightforward. There are reports of anti-TNF therapy stabilising or improving lung function in rheumatoid arthritis associated interstitial lung disease. And this paradoxical effect is also supported by some animal models. But I'm going to show you some BSR-BR data which looked at anti-TNF therapy and interstitial lung disease. So, this registry data would suggest that if you have rheumatoid arthritis and you have clinically apparent interstitial lung disease, chances are you are not going to do well irrespective of what treatment you have. So in the RA and ILD group who received standard second-line drug therapy, there's a 21% mortality after 2 years. In the RA-ILD group who received anti-TNF therapy, there was a similar mortality after 4 years. Now, the anti-TNF cohort did have increased mortality attributable to accelerated interstitial lung disease, which might represent reported bias. But overall, the mortality in patients with RA-ILD was not increased following anti-TNF therapy compared to the non-biologic DMARD group. So in crude terms, one can say to the patient, you have clinically apparent interstitial lung disease, you're not going to do well, probably you have 20% chance of dying in the next 2 to 4 years. I could give you this drug. It won't change the risk of whether you die or not, but it could change what you die. It could increase your risk of dying from interstitial lung disease. Now, clearly, it's a very crude statement. You would form your conversation in that way, but that's what the data would suggest. So, how UK rheumatologists select patients with pre-existing ILD, at least, did not seem to lead to an increase in all-cause mortality. But interstitial disease has generated a lot of concern in the rheumatology community. What do we do with patients like this? Can we give them anti-TNF drugs? Can we have a conversation about mortality, cause of mortality? What else can we give them? And of course, the risk of causing acceleration in interstitial lung disease. It's difficult to quantify with other agents, but it's not nil. And I personally have had patients who have died from interstitial lung disease, acceleration in interstitial lung disease, from all of these standard second-line drugs. Sorry, excuse me. And there are case reports of this happening with rituximab, there are case reports of this happening with tocilizumab. So, as ever, absence of evidence is not evidence of absence of these newer drugs, although the data is not so concrete that this possibly a flavour that they may also accelerate interstitial lung disease. But the important statement, I think, amongst all that is clinically apparent interstitial lung disease. And here's an absolutely hopeless piece of information there saying the prevalence of RA-ILD ranges something between 1 and 18%. Now, clearly, you can't use that kind of data in routine clinical practice. What on earth does that mean? Well, it's very variable because of how hard ILD was looked for, what was classified as ILD. And most patients who have interstitial lung disease are not symptomatic, and it is not clinically apparent. As ever in medicine, we're weighing up risks against benefits. In defense of medicine, I'm not going to give you this drug because there's a small risk of this happening against our limited understanding of the risks involved. And also, of course, defense of medicine would tend to ignore the enormous benefit most patients derive from anti-TNF therapy. And as ever, it's down to us as clinicians to make a judgment, to try and inform the patient, to try and engage the patient with that difficult decision. Anti-TNF drugs in pregnancy, again from ESR, BR data. FDA categorises anti-TNF as category B, i.e. animal studies didn't demonstrate a risk, but there's not adequate studies in humans to know. So caution, essentially, and I would advise women not to conceive when they're on anti-TNF drugs, really because of lack of evidence.
2 minutes, please.
2 minutes, sorry. Quite a variation in how long women should be off anti-TNF drugs, 3 weeks for etanercept before conceiving. There is a little bit of data on safety, such as no apparent increased risk in premature births, whether you're on an anti-TNF drug or not, though a trend towards increased risk of spontaneous abortion if you're on an anti-TNF drug. Well, those patients were also treated with fluoride. I mean, more of these agents do put pregnancy at risk. Sperm characteristics in men, very small numbers. This is in patients who have spondyloarthropathy, not rheumatoid arthropathy. And the data would suggest that sperm quality and function is not affected by anti-TNF therapy. But again, very small numbers. In fact, in this group of patients, sperm quality is affected more by highly active inflammatory disease than by being on an anti-TNF drug. Risk of malignancy, big concern at the start of these patients, or the anti-TNF agents may predispose to malignancy. RA itself is associated with lymphoma, of course, possibly the greatest risk in those patients with the biggest burden of inflammatory disease, such that maybe suppressing inflammatory disease with, for example, anti-TNF agents may reduce the risk of lymphoma. A meta-analysis of observational studies suggested that the risk of malignancy is not increased in the anti-TNF cohort, nor was an increased risk as time went by. There may be an increased risk of non-melanoma skin cancer, however, although this included registry data which relied on physician reporting of malignancy by a pathologist, so perhaps not that reliable data. But if you look at cancer registry data where the diagnosis was secure, then it seems that RA is associated with increased risk of keratinocyte skin cancer, but the risk is not increased further by anti-TNF therapy. If you have basal cell carcinoma in the past, you have a high risk of having it again, but the risk is not increased further again by anti-TNF therapy. Melanoma may be different, however. Again, going back to the SRVR data. Melanoma seems to be more common as a second malignancy in patients who are on an anti-TNF drug, although very small patient numbers again. And I say to patients, there's conflicting data as to whether these agents mortality in patients with rheumatoid arthritis who are on anti-TNF drug, overall mortality is not increased. The trend towards reduction in circulatory disease, even neoplasm, respiratory disease, a trend towards rather than demonstrating a reduction. But quite reassuring data from a large number of patients that mortality is not increased in anti-TNF cohort. And finally, biologic therapy algorithm. Well, there are lots of therapeutic options available, as I've said. We really don't have enough information on differential efficacy and safety, and as ever, it comes down to down to us as clinicians to make a judgment about that. There were some guidelines published this year by EULAR, European League Against Rheumatism International Group, which wasn't that very helpful, to be honest. But if you have active rheumatoid arthritis, you go on to a biologic drug. UK practice would be normally onto an anti-TNF drug, maybe tocilizumab if you're methotrexate intolerant, and then you cycle through really subsequent biologic drugs. The goal, of course, always is disease remission. Our target in rheumatoid arthritis is much higher than it was 10 to 15 years ago. Thank you very much.
Thank you, Dr. Mahfouli, for this interesting talk.
About reducing the burden of extra-articular disease in rheumatoid arthritis, start focus on what might be thought to be standard extra-articular manifestations of RA, as well as cardiovascular disease, osteoporosis, and at this time at the end, cervical myelopathy. So about 30% of patients with rheumatoid arthritis at some stage of the disease develop nodules, which might be thought of as an extra-articular manifestation of RA. If you have nodules, you're probably seropositive rheumatoid factor or anti-CCP antibodies. And severe extra-articular rheumatoid arthritis is usually seen in those patients who have nodules. Sometimes the extra-articular manifestations or the nodules can precede the articular disease, but severe extra-articular RA usually occurs in those who have long-standing severe RA, and it's associated with increased mortality. There's a broad spectrum of extra-articular manifestations of RA, ranging from the relatively benign nail fold vasculitis. This is a slide here of someone who has some nail bed infarcts and a splinter hemorrhage, through to more major organ involvement involving pericardial or the pleura, Felty syndrome, the eye, or interstitial lung disease. Certain scleritis and interstitial lung disease may necessitate the use of quite potent immunosuppressive therapy. Nail fold vasculitis on its own is not an indication to treat aggressively, but should alert you to the presence of other features of vasculitis being present. Some evidence that actually severe extra-articular RA is becoming less common. This is from a UK study in Norfolk, South East England. It found that the hospitalisation rate for SRV, systemic rheumatoid vasculitis, fell over the 14-year period from 11.6 per million to 3.6 per million, which might be compatible with the idea that we treat rheumatoid arthritis more aggressively nowadays. We probably have better agents to treat it, and that might lead to reduced severe extra-articular RA. How to treat severe extra-articular RA is limited evidence-based, really. It's mostly from clinical experience and expert opinion. There are some open trials. And cyclophosphamide is considered the treatment of choice for severe disease. By that I mean severe ocular disease such as scleritis or retinal vasculitis, or rapidly worsening interstitial lung disease, or rheumatoid vasculitis. There are other options available, but the evidence base for these is even slimmer. But if you're stuck, this is something to fall back on. TNF agents or rheumatoid.
For all the speakers, they are really covering very fruitful and hot dynamic topics. My first questions to Dr. Mahfouli. In a patient with rheumatoid arthritis, while he's on methotrexate and he developed interstitial lung disease, how you can evaluate the case that this is related to methotrexate side effect or because of the disease activity? This is my first question. My second question is that there are several studies showing that early start of combination biologics with methotrexate is superior to using DMARD. And we know that rheumatoid arthritis is a long life disease. It is a multi-systemic disease. And there is no cure from rheumatoid arthritis. And the time means joint function. So why there is controversy, some of them preferring to use DMARD, true DMARD before shifting to combination of methotrexate and biologics after failure of true DMARD treatment.
Yes.
And sorry, there is one question to Dr. Alai. Dr.
I
Alai.
allow for two questions. Enough two questions for you. If we have time, or if you can, at the end, you can ask Dr. Other.
The second question is it's a very good point. I think it's just down to cost. They are very costly drugs. The UK NHS could not afford to treat early rheumatoid arthritis with biologic drugs. So there's a trade-off there. I think if a relative of mine developed rheumatoid arthritis, I would want them to be started with the methotrexate with rapid escalation in dose after 3 to 6 months if they were not a lot better. Remember, our third of patients with MRA do go into remission with methotrexate monotherapy. But if they are not substantially better, then if money was no object, then I would put them onto an anti-TNF drug and miss out the second drug. But we are bound by cost. It used to be safety, but I think the safety issue is becoming clearer as time coming by. Time going by, it's easier to make that judgment now than it was at the start when our guidelines first came. And the first question, that's a difficult situation. There's not a straightforward answer. So does this patient have methotrexate-induced lung injury? Do they have RA associated interstitial lung disease? A high-resolution chest CT might be helpful in discriminating between the two. If there are other features elsewhere of active RA, that might help. But really, it's a clinical judgment. And often in that situation, I would stop with the methotrexate and switch them to AZA5. But it's a difficult judgment to make. It just doesn't get into clinician judgment.
Just
Okay.
a
So, Mohammed?
just a comment about anti-TNF and DMRs, basically the methotrexate. They are almost comparable. I mean, the methotrexate and TNF. And TNF not much superior if used alone without methotrexate. So we use both of them. So you cannot use just TNF. And as our guest speaker mentioned, the cost is so very important, especially in this part of the world.
Thank you. I want to comment just two short comments on Alaa's talk. The first is regarding the use of cyclophosphamide for lupus nephritis because of the past 6 or 7 years. Most of the trials, or almost all trials, prove that there is no superiority of cyclophosphamide over the MMF steroid regimens for lupus nephritis. So we as nephrologists adopted steroids MMF regimen rather than cyclophosphamide. So it's as effective with less side effects. This is regarding cyclophosphamide in lupus nephritis. The other thing is, I don't know whether it is a pure chance or the epidemiology has been changed because in the past 2.5 years I have been consulted to 26 patients with lupus nephritis and 7 of them were males, so is there anything changing? Because this 10 to 1 female to male, I don't know whether it's still valid or
Well, I mean, I'll start with the second question. I don't think, it's still valid. I mean, it's a disease of female, unless you are talking about, elderly patients, and sometimes that almost equal, male and female in the hospital, but still it's female. We often see, male sometimes. It's well known since it's female. Regarding cyclophosphamide, we rheumatologists, I think we are different. That's why we we ask our nephrologists, please send your patients to us when they have, from the start as a lupus patient, when they have lupus nephritis. We think we are, quite, comfortable dealing with these patients. The gold standard is still the lupus, the St. Thomas recommendations, ULR recommendations, ACR recommendations. They all recommend using cyclophosphamide, especially for induction therapy. Maintenance therapy, I do agree with you, unless there are contraindications for cyclophosphamide. There are reports, I do agree with you. Reports, comparing cyclophosphamide and Canavan or tacrolimus as well. But still, our practice is using cyclophosphamide. I don't know if
Okay, last question.
Thank you. Excellent presentation. Our body is in balance. TH2 with TH1. TH1 is cyclotron, which is interleukin 6, interferon gamma, and the tumor necrosis factor. These three, in SLE and rheumatoid and vasculitis, is overactive pro-inflammatory overactive of this limb. And you are separating it by treatment. Now, on the other side, there is TH2, now interleukin 6 and interleukin 10. If we increase, my question here, if we treatment, instead of suppressing this one, TH1, if we increase, activate TH2, now interleukin 4 and interleukin 10, and improve the intestine. Why intestine? 80% of immunity is in the gastrointestinal tract. If both of them improve this one and the gastrointestinal immunity, and then the TH2, interleukin 4 and interleukin 10, can we, without suppressing cyclosporine and all these things, without cyclosporine or all these things, or anti-tumor necrosis factor, or interleukin.
Your question for?
My question, can we, if this balance, increase this one, because it is
for which of our
anyone
speakers?
Because if we improve this one.
Okay, one of Dr. Khadr will explain to you, because our time is over. Dr. Khadr will talk to you.
Why I am saying this? Because if there is now bronchial asthma, there is separation of interferon gamma.
Can I answer you briefly, because I'm sorry. You see, most of the breakthroughs in therapy for autoimmune disease has been on finding medications that can target specific cytokine or one arm of the immune system. I'm not aware that when there are studies that you can stimulate one of the T cells to overcome the inflammatory part of the immune system. So that's not, I don't think that's probably achievable industrial-wise. I'm not quite sure if people are working this. Why should you stimulate one arm and expose the other arm? Why don't you suppress the culprit arm, the one which is causing the damage? And it makes sense that if you find a target medicine, that you can target specific cytokine, that will be much more easier rather than stimulate an arm that you don't know what will be the consequences of stimulating.
Shukran, thank you.